And my grandson is sicker crap.
Yeah, she told me.
Yeah.
My poor baby is so sick. I was up until like 2, laying with him on and off. And then he'd fall asleep, and then I'd sneak out and try to lay in my bed. And then next thing I know, Mommy, Mommy. And I'm just like, oh my God. So at one point, I was like, okay, this is not going to end. So my husband was staying home with him today. And I was like, dude, get up. Because I will be up all night. Like, I will be up all night if you don't get up and start doing something. And I have a good husband. I got some good mans. He's a good daddy. So he took the morning shift. I had the night shift. Well, we split the night shift, I guess. And now he's home with the stinker. I was in the ER with my daughter Friday for the flu.
Yeah, she had a fever of 104, and the school
and it
called,
was
so I took her
103.
to Akron's Children, but there was a couple people from her same class that were being removed when I got there for the same issue. Fever,
Yeah.
viral illness.
Yeah, so every time there's a medical concern at his school, we get an email that says, Flu B was just detected in your pre-kindergarten classroom. And I'm like, yay, me. Yes. I'm so happy. And it just sucks because we literally just got over being sick. Like, he just got done being sick. I just finished my antibiotics last night. I don't want to get the flu. I'm so scared I'm going to get the flu. I just can't even. I just can't. I can't. Okay. We're going to get started on neuro today. Yay. I like neuro. Neuro is probably like maybe like 4th down on my list of things that I like. Don't get me, it gets worse. There are things at the very bottom of the barrel, like nutrition, that I really hate talking about. So, any questions before we get started? Like I said, we can't talk about the exam. But any other questions before we get started?
Can you wait like 30 seconds? I'm trying to load this PowerPoint.
I would love to wait. I wish I could wait more than 30 seconds, to be honest with you. If I was not lecturing, your girl would not be here right now. I'd be home with my sweet baby, cuddling him. He woke up and he goes, Mommy, I'm sweating again. Oh my God. Poor child. You know what? Speaking of that, while we're waiting, let's disinfect our areas.
Yeah.
Let's do that. There's disinfecting wipes right there. Because who knows when the last time these tables were wiped? Say, I bet you that the last time I wiped my table was the last time that table wiped. So I am going to disinfect my area. Whoops. Cancel.
I got a lot of stuff again.
You could always wait until after.
Right.
I was just taking the opportunity, you know? Oh yeah, she gets it too.
Yeah.
I put a table outside the room
I didn't realize I was muted.
so I can deliver beverages and stuff, food right for their door
Yeah.
and medicine. They're all teenagers now, so it's easy to be like, here, take your temperature. Do this, here's your food, here's your drink.
Now get away from me.
Hide in your room.
Keep your germs to yourself.
When you have 5 kids, it's never ending when they get sick. When they were little, it's like one would start to get better, the next one would hit. One would start to get better, the next one would hit. And then I'd get it. And then it goes through the rest of them, and then I'd get it again.
Yep. This is another reason why I only have one child. And I will not be having any more. This baby factory is closed. Okie dokie. Are we ready? Oh,
Yes.
okay.
I
Already
privately
is
messaged you, Miss Simmons.
Okay. Good question, but that was not the key to the question. Okay. All right. Wish I could say that. Wish you could say what?
Because you said your baby factory machine. I said I wish I
Oh,
could say that.
yes, girl. Closed. Let's close. Okay, let's go. Complex neuro. So we're going to be talking about increased intracranial pressure, ventriculostomy, drains, the different types of drains, and measurement systems. Encephalopathy, different causes of encephalopathy, hospital-acquired delirium versus dementia. Delirium and dementia are two completely different things. Brain tumors, strokes, TBIs, which traumatic brain injury, and then spinal cord injuries and what happens at the levels of injury with spinal cord injuries. We're going to learn, if you have never met anybody with a spinal cord injury or taken care of these patients, every injury is different. Even if it's the exact same place in the same 2 people, there's going to be something about them that is different. Because the nerve pathways, yes, we have an idea of exactly how it all is, but I don't know about you guys, like I have a lot of tattoos, right? And when I get tattooed, there's sometimes where I'm getting tattooed in one place and I feel it in my back. And I feel it in my arm when it's my leg. Or I feel so go ahead. Okay. So our nerve pathways, even though we have an idea of exactly how it's supposed to be, doesn't mean that that's how it is in every single human. Okay. So with our neurological system, we have 2 nervous systems. We have the central nervous system, which is our CNS, and we have our peripheral nervous system, which is our PNS. So
Miss Simmons,
yeah.
are you able to share your screen?
Oh, I thought I did. I did.
Yeah, her
I
screen
can
shared,
share it.
Amanda.
I can see it.
Are you seeing it behind her or a whole other screen?
I can see a whole separate screen.
Yeah, I don't see it either. Oh, there it
Okay,
goes.
now I see it.
There we go. Now we're cooking
you.
with gas. All right. So we have our central nervous system, which is the brain and spinal cord. Obviously, we have multiple different parts of the brain. In this picture, it shows you the cerebrum, the brainstem, and the cerebellum. We also have the temporal and the parietal and the occipital. And then the spinal cord is made up of nerve cells that carry messages between the brain and the rest of the body. Okay. The peripheral nervous system is then broken down into two other systems. Okay. It is the SNS, which is the somatic nerve system, and then the ANS, which is the autonomic nerve system. Okay. So, our central nervous system, our CNS, we have our parietal lobe, which is responsible for sensation and visual perception. The frontal lobe is responsible for motor control, problem solving, and expressive speech. This is also where Broca's area is. Broca's area is responsible for speech. The occipital lobe, which is all the way in the back here, back to your noggin, is for sight and visual perception and interpretation. So the difference between parietal and occipital is the occipital lobe is responsible for interpreting what we see. Okay, the interpretation is the difference. Our temporal lobe, that's where we have auditory processing, memory retrieval, and language interpretation, which is where Wernicke's is. So if you have a stroke in the frontal lobe, in Broca's area, then you won't be able to speak or have issues with expressive speech. If you have a stroke in Wernicke's, then you would have issues interpreting what you hear. Okay? You can speak, but when someone talks to you, you're like, that's another language. I don't know what they're saying to me. Okay? Which I don't know which is worse. I think Wernicke's would be worse. But I wonder, because the brain is so interesting, I wonder if even if you can't process the words that they're saying, you could read what they're saying. I bet you that you still could read it, which is really interesting. The brain is a crazy place. We're not doing that. Okay, cranial nerves. You must know these. This is very important. Very important area. Okay? So, there are a lot of different ways to remember the cranial nerves. There's little pictures you can draw. There's little sayings that people memorize, mnemonics or whatever. You do whatever you need to do to remember these cranial nerves, okay? So cranial nerve 1 is your olfactory nerve. This is your sense of smell. If you think about it, you only have one nose. So cranial nerve olfactory, this is number 1. You have one nose. The test to test the function is to have the patient,
Sorry. Can you please let Marissa Johnson in?
Yeah.
Thank you.
Okay. The test is to have the patient identify a smell of substance with eyes closed. This is not a hard to identify smell. This is a very identifiable smell, like coffee grounds, or the first thing that came to my mind was bleach, because right now all I can think about is how nice it smells in here because we just cleaned our surfaces. So something that is a very recognizable smell. Okay. A normal response obviously is that they can correctly identify that smell.
Sorry, I need the tablet.
Okay. So then we have cranial nerve 2, which is our optic nerve. If you think you have 2 eyes, so this is your second cranial nerve. The test is your Snellen chart. We've all done that. Our kids have done it, especially if you have glasses, you went to elementary school, you stand 20 feet away from the thing and you read the letters and you read as far as you can down. Okay. You can't read them down. Guess what? You can't see. And you're supposed to cover one eye at a time. So a normal response is to be able to read with each eye and both eyes together. Now, granted, the vision, yes, is dependent on the optic nerve, but there's also a lot more to do with visual perception, like your cornea and your rods and cones and whatever else is inside of your eyeballs, right? So vision, and especially the clarity of vision, nearsighted, farsighted, is a lot deeper than just your optic nerve, right? Cranial nerve 3 is your oculomotor. This is your upward eye movement and pupillary reflex, okay? So the test is to use a pen light to check light reaction and finger to check accommodation. So this is when you have your pen light and you're going up and they're following the pen up with their eyes, not with their head, with their eye movements, right? This is also when you're checking pupillary response, so constriction. And then also when you're bringing your finger towards the nose or bringing a pen towards the nose. If you notice, if you even do it to yourself and you're looking at that finger, your eyes are going to go towards whatever's coming towards your face. That is a normal response. Okay, so the normal response is that the pupils constrict equally when brought towards the nose and when exposed to light. So not only do the eyes go in towards the object, they also constrict towards that object. And then there's a little note over here that says often tested together is cranial nerve 3, 4, and 6. And that's because that's where we do all of our cardinal gazes and perla and all that good stuff. Okay. So number 4, this is your trochlear. This is your downward and medial eye movements. Okay. Oh, I guess my statement was a little bit off. Because this says the test, use a pen light and move it medially and downwards. Medially, I feel like that's towards the middle. Right? So with cranial nerve 3, the normal response is the pupils constrict when you have something coming towards it. Cranial nerve 4 is the eyes can move medially, meaning inward, and downward. Okay? Medially is towards the middle. Anyways, sorry, I just had a moment. Number 5, this is your trigeminal nerve. This is for facial sensation and chewing. So if you notice, this is the first one that has 2 different tests. One is sensory and one is motor, which means it has 2 functions. Okay? So your facial sensory test is to use a sharp and dull side of a pen to check for sensation with the eyes closed. This is literally like having the patient close their eyes and touching them, obviously not a sharp like needle, right? But like if your pen has a cap that has like the thing sticking out, right? And you use that and you kind of poke, like that would be sharper than the opposite side of the pen that's flat, right? So the sensation between sharp and dull, okay? And then motor, ask the patient to clench the teeth with resistance. So like actively clenching the teeth, Your normal response is that the patient can distinguish between sharp and dull, and that's the sensory portion. And then the motor portion is that they can open the mouth against resistance and bite. Okay. Cranial nerve 6, which is your abducens. This is your lateral or sideward eye movements. So it says think of abducens as abducides. Abducides. I don't know. That doesn't do anything for me. The test is to use a pen light and move it sideways. The normal response is the ability to move the eyes laterally. So cranial nerve 3, 4, and 6 are all of your cardinal gazes. Okay. So 3 is upward eye movement. 4 is downward and medial, so inward. And then 6 is lateral, so side to side eye movements. Okay. The only one that has to do with anything about pupillary constriction is which one? 3. It's the only one. The only one out of all 3 of them that has anything to do with the pupils constricting. Is the pupil a muscle?
Yes.
Yes. What type of muscle is it? It's like your butthole. It's a sphincter. Okay? We have multiple sphincters in our body, right? We have the sphincter that is between the esophagus and the stomach, our esophageal sphincter. We have the sphincter that's between the stomach and the duodenum, which is your pyloric sphincter. We have the rectum, which is your rectal sphincter, right? And then we have our iris. Our iris, the color part around your eyeball, is a sphincter muscle that is able to open and close, dilate, and contract.
So
Okay.
does anything that dilates and contract, is that what makes it a sphincter, or is it like the little rigid stuff around it? Like the edges?
That's a great question. I almost want to say both, but I would have to look it up to answer you like 100%, but I feel like it would be both. Because most muscles, or if not all, I mean, skeletal muscles, they do not open at all. So another thing about a sphincter is that it's circular, like it goes all the way around, and its job is to open and close, open, close, open, close, into response to something, right? The pupils, the iris, is responding to light, to accommodation of light. Your esophagus is responding to food. Your pylorus is responding to digested food. Your rectum is responding to the colon being full and ready to expel. Okay? So, good question. I think it's both. So also, if you notice too, at the bottom of each square, it tells you whether it's sensory or motor, which I really feel like that's kind of self-explanatory, whether it's a sensory function because you're sensing, you're feeling, right? Something, or you're using some type of sensation. We have 5 senses, right? We have seeing, hearing, tasting, smelling, touching. Right? You have your 5 senses. So if any of these have anything to do with the way that you feel, see, smell, touch, taste, then it has to be sensory. Okay? If it has anything to do with any type of muscle movement or nerve movement, it's going to be motor. Okay? Make sense? Yes?
Yes.
All right. All right. Moving on. So now we have facial nerve 7. cranial nerve 7, which is your facial. This is for facial movement and taste. So it's both. So your test here is for sensory to taste test on the anterior tongue, sweet and salty. If you've never learned about the tongue is actually separated into like segments where some parts of the tongue is responsible for sweet, some for salty, some for bitter. So the anterior, like the front of the tongue, is responsible for sweet and salty. And the normal response is to be able to distinguish that taste. For motor, it's to ask the patient to smile, raise their eyebrows, close the eyes, and puff out the cheeks. When I did my assessment for, I had to videotape an assessment every week on my husband for my BSN, or actually no, it was for my master's health assessment class. And it was really funny asking him to do this. You should have seen us. We were like two teenagers in my kitchen after we put Henry to sleep, trying to do this on video. And then you have to like do peer responses to other people's videos. So like other students are watching your video. It's terrible. Absolutely terrible. Anyways, the normal response is to be able to perform facial expressions without difficulty and on both sides, right? Girl, do I have to close those blinds? I'm gonna have to close those blinds. You can close them. My distracted girly back there. Okay.
So bad.
I know. She's just daydreaming out the window. All right. So cranial nerve 8. This is your vestibular cochlear. This is for hearing and sense of balance. The test is this is the whisper test. So you whisper something near the patient's ear and they are able to hear you. Balance, you ask the patient to walk across the room and back. And then the normal response is that they obviously can hear you clearly in both ears and they're able to stand and walk upright while maintaining balance. Cranial nerve 9, which is your glossopharyngeal. So this is another situation where med term really comes in handy, right? Glosso means tongue. So glossopharyngeal, pharynx. So this is the throat sensation, swallowing, and salivation. Sensory is taste test on the posterior tongue, which is where sour and bitter is. And then the motor response is to have the patient say, ah. We do that for a reason. And the reason is when you say, your uvula rises symmetrically when you say it. It's not just because they want you to say, stick your tongue out and say, there's a reason for it, okay? And then distinguish the taste. There's a little star over here that says, cranial nerve 9 and 10 work together for gag and swallow. This is going to be very important when we talk about brain death criteria and how people meet that criteria to actually be pronounced brain dead. What is in that cup?
Ice.
Oh, okay.
It was a lavender cream chai.
Oh, it's empty. Oh my God, that freaked me out. Okay, sorry. All right, so cranial nerve 10, this is your vagus nerve. Your vagus nerve is very important. It's a very important friend in your body, okay? It has so many responsibilities and so many ways to make things really weird. So, it has things to do with your digestion, your heart rate, your respiratory rate, your immune system, swallowing. The way that you test this is that you use the tongue blade to touch the posterior pharynx to test the gag reflex. And the gag reflex should be assessed followed by a swallow, okay? The vagus nerve can be very sensitive, okay? Your vagus nerve runs all the way from your brainstem, all the way down to your butt, all the way down to your butthole, okay? So that's why when you bear down, okay, it can change your heart rate. That's why whenever you have surgery that messes with your stomach or messes with anything, like specifically, I had a gastric sleeve. So if I eat too much and my stomach is like triggered and it stimulates my vagus nerve, I start sneezing. Immediately, I start sneezing. That's how I know I'm full, other than I'm full. Okay. Other people, they will start hiccuping, or they will start, their nose starts to run. And this is also how people die on the toilet, because they're constipated, they're bearing down, they're trying to push the poop out like Elvis, okay? And he triggered his vagus nerve, which affected his heart rate, which his heart stopped, okay? So the vagus nerve is very important. Also, if I get hiccups, I get hiccups if I eat too much because of my bariatric surgery. Yes, exactly. So, another thing, especially when we start talking about arrhythmias, when you have a patient that comes in with SVT, supraventricular tachycardia, the very first thing you do for that patient is tell them to do a vagal maneuver. Bear down, cough really hard, blow through a straw, because you can stimulate the vagus nerve enough to get you out of that arrhythmia. Does it work? Sometimes. 2 out of 10 times, maybe, if that. So then moving on to the cranial nerve 11, which is your accessory nerve. This is your shoulder and neck movement. The test is to shrug the shoulders, turn the head side to side, especially with resistance. So you put your hand on the patient's face and they turn their face against your hand on both sides, okay? And they're able to shrug their shoulders. So normal response is that they're able to shrug shoulders and turn head to each side without difficulty. The last one, your cranial nerve 12, this is your hypoglossal, hypo meaning under, or yeah, under. So under the tongue, this is for tongue movement. Ask the patient to protrude the tongue, bless you, and move it in different directions. The normal response would be to be able to move the tongue without difficulty. Okay, so, oh, Carly said, me and everyone on my dad's side has vasovagal syndrome, aka we easily pass out over weird triggers. What is your main trigger, Carly?
For me, it's if I stand too long or funnily enough blood. I'm not afraid of it, and I want to work in emergency, so I'm just gonna make myself get over it.
Yeah. So I always said I don't have an issue with blood. Never have I ever had an issue with blood. But we're going to talk about fight or flight. I have a fight or flight response when it comes to seeing a lot of blood. I never experienced it in the OR. I only experienced it because that's very controlled. It's a very controlled amount of blood loss, hopefully, unless it's like a trauma. But the only time I ever experienced it was when I worked in the ICU, and there was just like an uncontrolled amount of bleeding, or you didn't know where the blood was coming from, and it was just like happening. And this was also earlier in my career, where I'm still learning every day, but in that time, it was very much like in my infancy of nursing, where I was really learning so much, and my body would just respond. I mean, heart racing, like just this response, this autonomic response of like, oh my God, okay, what do I do? How do I figure this out? You know? And I would always be able to act in the moment. Like it would never be like a paralyzing thing. But I used to always get so annoyed that like, okay, I need to see blood enough where I don't respond this way, because I have no control over this like heart racing feeling of like oh my God, the world's about to end, like situation. Like, and I hated it. I always hated it. So, anyways, my friend has vasospasm. Hers is blood too, especially her own. Yeah, that's not fun. I've never passed out and I never want to.
Miss Simmons, can you let me
Okay. Yeah.
on the computer?
Yes. Any questions on our cranial nerves before we move on? Do you need to know this? Yes.
I have a question about that.
Yeah, go ahead.
I don't know if this sounds stupid. Do we need to know like the olfactory nerve is one, or just know that olfactory nerve and this is what it does?
Both.
Like all three, one, name, and purpose?
Yes.
Okay, thank you.
You guys can watch these videos on your own. I don't like incorporating videos into class because most of you guys just like drown them out and don't listen to them anyways. Am I correct in saying that?
What would
be
be
honest.
what would be an example of like how you would ask a question about the nerves?
Girl.
I'm
don't even
just
know.
saying somebody might not understand like how
don't
it might be
remember.
worded.
Yeah. I don't know. I'm gonna have to think about that. Like say you were asking a question about sweet versus salty. Like if I wanted to test cranial nerve 7, what type of food would I give my patient? Would I give them a Snickers? Would I give them a lemon? You know what I mean? Like it's being able to interpret the information, right? It's not always black and white. It's not always what is cranial nerve 1? A, B, C, or D, right? I mean, yeah, it would be great if it was always like that. But the thing about critical care and what is most important for you guys to understand is that in these last couple months and over specifically the next 2 months, I am going to be expecting more and more and more critical thinking and critical judgment. So it's not just about knowing the information, it's about being able to apply that information, right? Within the entire nursing process. How do I assess? How is it diagnosed? What is the plan? Okay, what am I implementing? How am I evaluating? If that evaluation isn't what I want, then what do I do? Who do I call? Okay, what should I expect? So it's really, truly putting it all together. Okay. All right. So moving on to the peripheral nervous system. This is the nerves that are outside the brain and spinal cord. So you have your somatic nervous system, and then you have your autonomic nervous system. The somatic nervous system controls all 5 senses and movement. So this is your sensory neurons and your motor neurons. Your autonomic nervous system controls involuntary physiological processes that include the sympathetic and the parasympathetic. This is your fight or flight versus rest and digest. Okay. So the somatic nervous system, sensory neurons, it is the rest of the body telling the brain. So that means I have my hand and I put my hand on the stove. The sensory neurons in my hand tell my brain, hot. Okay? My hand says hot, and it tells my brain, hey, don't touch that, it's hot. Okay? So motor neurons is my brain telling my body. So that is my brain telling my hand to touch the stove. even though you probably should. I mean, hopefully it's not one, right? But also everything that your brain tells your body to do: walking, talking, swallowing, eating. Okay? Wiggling your toes. Your brain tells your toes to wiggle. Okay? The peripheral nervous system, broken down to the autonomic nervous system, which then breaks down to the sympathetic versus the parasympathetic. Okay? Your sympathetic nervous system, this is your fight or flight response. Okay? I have to fight for my life. What do I need if I'm fighting for my life?
Energy.
Adrenaline.
Energy, adrenaline. What did somebody else say?
Oxygen.
Oxygen. Ding, 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 ding. It all comes down to oxygenation. Okay? What is going to get me more oxygen so that I can create more energy and I can fight for my life? The harder your heart works, which is your increased heart rate, tachycardia, the faster the oxygen is going to move through your body. If my heart is working harder, trying to get more oxygen flooding my body, what else needs to be higher?
Your blood sugar?
Not yet. My respiratory rate. I need to breathe harder and faster so that I can take in more oxygen. Because if my heart's pumping all of my blood faster and faster and faster to try to get more oxygen, but I'm not breathing any faster and I'm not taking in any more oxygen, then that's not going to work very well, right? I need both tachypnea and tachycardia to work together to deliver oxygen to my tissues. Does that make sense? Okay. I also, if my cardiac output is higher, I also need higher pressure to get that blood to where it needs to go. I need my pressure to be higher so that all of my oxygen gets to my brain, gets to my lungs, gets to my heart, gets to my feet so that I can run faster. Okay? So increased heart rate, increased blood pressure, increased respiratory rate. Okay? Dilated pupils. Why? I need to be able to see the bear. Okay? I don't care what time of day it is. My pupils are getting so big that I am like an owl. I'm like, where is it? What? I can see anything moving. Okay? Stop salivation. Ain't nobody got time to be drooling while I'm trying to fight the bear. Okay? And really, you really shouldn't fight bears. You should like lay down. So I'm fighting a man in the woods. Okay? I don't have time to salivate while I'm fighting a man in the woods. Okay? Increase blood sugar. Why?
Glycogenolysis. Did I say that right? Is it glycogenolysis?
You didn't say it perfectly, but it's perfect to me, girl. Glycogenesis. Okay? So, do I have time to say, excuse me, sir, please don't murder me. I need to eat real quick. No, let me get a bite of my protein bar, sir. Please stop. Don't cut my face off yet. Time out. No. So where's my stored glucose?
In the liver.
In my liver, in the form of glycogen, where it gets broken down by glycolysis, where it's used in the form of glyconeurogenesis in ATP. ATP is the energy production within the cell. Where? Made by who? Who makes ATP in my cell? The mama.
The mitochondria.
The mitochondria. It's all coming together. for increased cellular energy. Okay? So, relaxes my bladder. Oh, that's another sphincter. You have a urethral sphincter. It keeps your pee inside, right? So, but the bladder wall is a muscle. The way that the muscle works is that it feels that it's full. So it says, hey, you need to go potty. Okay? But if my bladder relaxes, guess what? I'm not worried about going pee. I gotta fight this dude. Okay? Oh, sir, please hold. I must poop real quick. No. No. We don't have time for that. Okay? So no, I don't have time to salivate. I do not have time to urinate. I do not have time to defecate while I am fighting the man in the woods. No, I don't. So when you think to yourself how to remember these, what don't I have time for? I don't have time to digest anything, and I don't have time to pee, and I don't have time to salivate. What I do have time for is to breathe faster, my heart rate faster, my blood pressure higher, my liver working to get that sugar for energy, and my pupils are on point. Not on point, because they're not pointed. I mean on point, like I'm seeing everything. They're big, they're dilated, I can see everything. Okay? So, on the other side, I am no longer fighting the man in the woods. I am comfy in my bed, listening to white noise. My child is not sick from flu B. Everything is right in the world. I'm feeling calm and present in my body, and I'm laying there, and everything's just so great. My heart relaxes. My blood pressure relaxes. My pupils can constrict and calm down. I don't need to see everything. I can just chill, right? Bronchoconstriction. This is like, it's not bronchoconstriction like your airways constricting. It's more of you're relaxed enough, your body doesn't need all of this increased oxygen flow. Okay? So you're just, your bronchi is just chilling. It doesn't need to dilate and take all this air in. Okay? Contracts bladder. I gotta pee. I gotta get up in the middle of the night, I gotta pee. And stimulates digestion. This is where our intestines are working. We gotta go poop. Now you're like, well, Jess, when I'm nervous and anxious, I have to poop. That's not fight or flight. That's different. That's called anxiety. Okay? So are we clear about the differences between the sympathetic nervous system and the parasympathetic nervous system?
Yes.
Perfect. Let's take a break. Ten minutes.
You said 5 or 10.
10.
Okay.
So, additional parts of the nervous system. We have cerebrospinal fluid, which we call CSF. It is produced in the lateral ventricles and circulates around the brain and spinal cord through the ventricular system. There are 2 internal carotid arteries, and 2 vertebral arteries, and their extensive system of branches provide blood supply to the brain. Okay. We have a blood-brain barrier, which makes the central nervous system inaccessible to many substances that circulate in the blood plasma. I'm hoping that this is not the first time you've ever heard of the blood-brain barrier. There's a lot of medications that cannot cross. There's a lot of organisms that cannot cross the blood-brain barrier. What sucks is when the brain does get infected is when, or like what can we use to treat it? So that can be difficult.
Can you let Kaylee and she switched devices and she got home?
Thank you. Okay, so when we talk about our neurological assessment, we have our level of consciousness, which is person, place, time, events. So this is our way of asking if our patient is alert and oriented, right? So who are you? What is your name? Where are we right now? Most of the time I will accept hospital, even if, like, especially if your patient is already confused, you already are expecting confusion. I can still, in some level, say that my patient is alert and oriented if they're telling me their name and telling me that I'm in a hospital and it's March, right? Because when you're in the hospital, it's really hard to know what day it is. It's hard to know the exact date. Sometimes it's even hard to know the exact time, right? But it's definitely, and then if it's like the very beginning of the month or the last day of the month, and they say February, but it's March 1st, okay, like, come on. I even do that, all right? So using your nursing judgment to assess your patient's orientation is important too. So where are we? What month are we in? Events, do you remember what happened? My go-to was always, do you know who the president is? And people, depending on the person, they don't really like that question anymore. But it used to be like a funny thing when it all like first happened. And I'm not trying to get political in any way, shape, or form. I'm just saying it did used to be funny. Like it used to be like, oh, okay, you know, who's our president? And then you'd have some old lady be like, oh, I hate that guy, you know, and like they're just like, yeah, Trump, you know, like it's just like people are usually can be a little funny about it, but nowadays people are a little sensitive. So not that we don't have a right to be a little sensitive. Let's not get political. Anyways,
Miss
then
Simmons,
we have, yes.
can I say something?
Is it political?
No. But
Okay,
it's kind of
yes.
what you said. This lady, she was like disoriented to everything, but I asked her who the president was, but she knew that answer, but she ain't know her name or nothing else.
Amen, girl. Amen. My best friend, I think it was either her mom or her husband's mom. They were asking orientation and she refused to say Trump's name. Literally refused, flat out refused to say his name. And they marked her down that she was not oriented to events. And she was pissed. Then we have our pupil assessment, which is where our PERLA comes in. So pupils are equal, round, reactive to light, and accommodation. So pupils equal, it's not good if one pupil is bigger than the other one. Okay, that is not a good thing. Now, what is something, can you guys turn your cameras on, like my whole screen is black. Literally the only person I can see is Amanda O'Neill. Hi girl, thank you. I see nobody else. Okay, thank you, thank you, thank you. I'm expecting more. The cup. I don't even like to do all that. I'm just saying. It's not fun speaking to a black screen. Huh?
Can you see me, Brandy?
No.
I just popped on. Okay, it took forever.
Oh, there you go. Okay.
Hey, my
Thank you.
camera's on.
I appreciate
I don't know.
Who was that?
Melinda,
Oh,
is it showing?
yes.
Okay.
Thank you guys. I appreciate that very much. Okay. Anyway, what is something to consider when we see a pupil that may be different than the other one? No, something that could change the way that the pupil looks. An injury to the eyeball. Okay. So my high school boyfriend, his mom, when her kids were like toddlers, she was like putting together a swing set or something. I can't even imagine. A screwdriver went into her eyeball. Okay. And she did not lose the eye, but her pupil, I think it like tore the iris or something. So that eye, it cannot contract or dilate, and it has an irregular shape. And it will be like that forever. It never changes. It's literally like that forever. The eye is damaged. Okay. So it's important to know when you're assessing your patient's eyeballs, do they have a previous injury that could have changed the shape of their eyeball? Or is this an acute situation where my patient has a blown pupil and their brain is herniating and they're going to die? Okay. Two very different things, right? Round, both pupils are round in shape. Like I said, that can be changed with an injury. Reactive to light, both pupils can constrict when one eye is exposed to light. So it's not that only your eyeballs work together. They don't work. When you put light in one eye, the other eye is going to act in the same way because they work as a team. They don't work one for one or for the other, right? And then accommodation, both pupils constrict, and equally move to follow the finger towards the nose. Which cranial nerve was that?
Is that 4?
5.
3. 3. Cranial nerve 3 was the only one that had anything to do with the pupils constricting. Remember? Because you assess cranial nerve 3, 4, and 6 together when you talk about the eyes, when you talk about the cardinal gazes. Okay? So the only one that is responsible for accommodation would be cranial nerve 3, right? Yes, Jessica.
Yep.
Yeah.
Yes, ma'am.
All right. Yay. Okay, this is a big one. This sucks. Now, what I can tell you, I'm giving you a deal. I'm giving you a really good deal, okay? You must know how to determine your patient's Glasgow Coma Scale. You do not need to know how to calculate an NIH, which is worse. Totally the NIH. Are we going to go over NIH? Yes. The most important thing I want you to know about NIH, if the number goes up, bad news bears. An NIH score that goes up is bad. That means your neurological symptoms, your stroke symptoms are getting worse. Your GCS is opposite. The higher the number, the better off you are. The lower the number, the deader you are. You must know how to calculate your patient's GCS. Okay? So, this is a very fast way to assess your patient's level of consciousness, and it is used in triage situations. It is used in the ER. It can be used, really, it can be used for any situation, ever, in any day, anything. But the most of the time you're going to hear of a GCS coming from paramedics to nurses or trauma doctors, residents, and then them talking about that amongst each other. ER physicians talking to surgeons, if it's surgical, it is part of their assessment that is very, very quick. Okay? So, eye-opening. So I'm telling you, I'm walking into a patient's room. Okay? I'm walking into your room, your hospital room. And I say, hi, my name is Jessica. Well, actually, I don't say anything. I'm lying. I don't say anything. And you turn over and you look at me. Hi. That is spontaneous eye movement. Okay? She has spontaneously opening her eyeballs. Okay? I walk in, she has her eyes closed. I walk in and I say, hi, how are you? And she turns over and she opens her eyes. That's a 3. She opened her eyes to sound. Okay? A 2 is when she's not responding to me and I'm going to sternal rub her. Okay? This can be anywhere from, now let me put it this way. Unless the patient is deaf or extremely hard of hearing, okay, let me preface that. And you go over to someone, you're like, hi, hey, hello, how are you? And they're not responding to you. A light little jiggle of their hand is not really going to do it for them, right? Unless, like I said, they're deaf or extremely hard of hearing and they can't hear you, okay? So when I say to pressure, I mean real pressure. Like, hey, you, are you okay? Sternal rub, okay? And then number 1, there is no response. I'm sternal rubbing the out of you, which I just did that to myself and that hurt. Okay, do that to yourself. Put your knuckles into your sternum. Do it, girl. Harder. It hurts. You don't even have to do it that hard. You don't even got to do it that hard, and it hurts. Okay? Believe me, you would not have to do that hard to me before I'm like, I'm fighting you. I'm getting up off this bed and I'm going to fight you if you touch me again. Right? So, that is just for eyes, 1 through 4. Okay? Verbal response. Is the patient oriented? Okay? So, I know. She's like, I know. So, the eye opening, that is for alert. Yes? Alertness. Verbal response, this is your orientation. Is the patient oriented? Person, place, time. Okay? Number 4, is the patient confused? Okay? They're sitting there, they're talking to you, but they're like, the sky is green. I had a cord for breakfast. They're pleasantly confused, but I'm still talking to you. I'm confused, but I'm talking, right? Inappropriate. Okay, wait. Because inappropriate words, that's kind of back up the train, okay? Confused is confusion with orientation, right? They don't know what time it is. They maybe don't know where they are. Hopefully they remember their name. I feel like we're pretty far off if we don't even know our name, right? So then inappropriate words would be like, the sky is green, or I ate this phone today, right? That would be inappropriate. Incomprehensible speech is like, huh? Huh? Okay, I don't know what that means. Incomprehensible. I don't know what you just said. It was not English, not words. Okay? And then one, there is absolutely no verbal response. Nothing. Okay? Next is your motor response. Number 6, we shake hands. I tell you, squeeze my fingers, raise your arms, blah, 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 obeys commands. Yes? Normal. It's a normal response. Okay? Number 5, localizes pain. Okay? That means I press on your nail bed on your second toe and you say, ow, my toe. Okay? I can identify where the pain is. Number 4, draws away from pain. That means I just pressed down on your nail bed and you didn't say anything to me, but you pulled your foot away from me. Or I pressed down on your nail bed on your finger and you pulled your hand away from me. Okay? Press down on your nail bed. What?
Oh, they was doing that.
That shit hurts. You do it hard enough, that hurts. They do that in the ICU. Okay? Number 3, bend abnormal flexion. Okay? This is where we start talking about decorticate versus decerebate posturing. Okay? So flexion is the hands go inwards. They're flexing in. Okay? Extension, like this. Extension, which is number 2, is when they go out like this. Okay. Marissa just put in the chat, decorticate is to your core. Decerebate is out. Decerebate, worse. Neither of them are good, by the way. Neither of them are, but decerebate posturing is worse than decorticate posturing. Okay. And then number 1, I think that's the next slide, is the posturing. And then number 1 is no response at all. There's no posturing whatsoever. There's no withdrawal from pain. There's literally no motor response. Excuse me. This is very important over here on the right side. Your score interpretation, very important. Just put a star on this whole freaking page. Very important. So 3 through 15, by the way, 15 is a perfect score. Okay. So 3 through 15 is a mild brain injury, or really just no injury at all whatsoever. Because if you're 15, then I'm a 15. I hope I don't have a brain injury, right? But you could have a mild brain injury if you're lower than 15, 14, 13, right? 9 through 12 is a moderate brain injury. 3 to 8 is a severe brain injury. And anything equal to or less than 3 is a deep coma or brain dead. The lower the score, the worse your level of consciousness. Okay? It's extremely important to obtain a baseline upon admission and reassess per your facility protocol. Now, if you're looking at this list for interpretation and I ask you, at what point do you think your patient is going to need airway support? Less than 8, we intubate. Amen, girl. Amen, girl. Are you a paramedic?
No, I
Can't
worked
hear
in
you.
an ER. I did not hear that answer.
Less than 8, we intubate. Anything less than 8, that patient can no longer protect their airway, and they must be intubated. Okay, a GCS less than 8, we have to intubate. I like that a little rhyme, little trick. It's good. Okay. We will get to the posturing slide. I don't know where it is. Okay, so gerontologic changes to the nervous system. What happens normally when we age? Okay. Structural changes in our brains. That's normal. Motor alterations. We get slower. Sensory alterations. We're more sensitive to hot things, cold things. That's different than temperature regulation, by the way. We're more sensitive to taste. We're more sensitive to smells, or the complete opposite. We're less sensitive because we're losing hearing. We're less sensitive to taste, right? Then when we talk about temperature regulation, we're talking about the actual temperature of the person's body, okay? You know somebody's grandma out there has their heat set at 85 in the summer. You go over to grandma's house and you're sweating and you feel like you can't even breathe in her house. You're like, Grandma, what are you doing? It's so hot in here. She's like, and she's got a sweater on. She's cold. Because her temperature regulation has changed. Okay? That is a normal part of aging. That's why our elderly population is more at risk for heat stroke. Okay? Pain perception. This can change with neuropathies. I don't know if people get more sensitive to pain. I feel like less sensitive. And then mental status change. Now, this is not across the board, right? We've all met somebody that's 95 years old, as sharp as a tack, walks around the mall in the morning at 9 a.m., right? Crazy. And they're sharp as a tack, right? But then you meet someone that's 72 that has early onset dementia and doesn't know their name from applesauce. Okay. So a mental status change I don't know. I feel like it's so different with people. Like, is it really that normal? I don't think so. I really think it depends on the person, their comorbidities, and what they're experiencing. Because I have met some very, very sharp old people and some not so sharp, not older people. Okay. We already did that. Okay, so I told you I need you to know the difference between delirium and dementia. So, hospital-acquired delirium, what is it? This is a disturbance in cognitive abilities that results in confused thinking and reduced awareness of the environment. There is always an underlying cause of delirium. Something has made this patient delirious. Is it infection? Is it ICU? ICU, critical care, intensive care unit delirium is extremely common. Okay. What is the reason for the patient's delirium? So differences. Delirium occurs suddenly within hours to days. It has an underlying cause. It always has an underlying cause. It is reversible when the underlying cause is treated. Versus dementia. This occurs over time, over many years. We do not know the exact cause of dementia. There's also different types of dementia. And we have not found a way of reversing dementia. We have found medications that slow the progression, but it does not reverse the damage that has already been done. And then there's little red words here that say a sudden change in neurostatus is a medical emergency. Alert the PCP immediately. I feel like that's pretty self-explanatory, but it's in red just in case you didn't know. Very important concept. Okay. So, risk factors for hospital acquired delirium. Advanced age. You know, Granny is usually alert and oriented, but you take her away from her house and you put her in the hospital, and all of a sudden she's confused. My granny's not confused. She's not confused at home. Well, you changed her environment. That happens to people. They get confused sometimes. Okay. Secondary to medical conditions like an infection, a stroke, metabolic imbalance like hypoglycemia, chronic pain. Of course, medications, surgeries. Oh my God, I will never forget. I will never forget in a million years. This was before I was a nurse. I was a patient tech on a ortho unit at St. A's Boardman, 7 West, which is now 7 South, but it used to be 7 West. And this guy, this old guy, he had just got his hip done. He was in the last room on the left. And he was so crazy. I mean, he wanted to fight everybody. I'm not kidding. This dude literally came back from surgery that morning with a brand new hip. And he is in the hallway with his walker trying to fight people with the walker. Okay? I go home. Next morning, I walk in. I walk past his door and he says, he's waving. He's sitting in his chair waving to me. Like nothing ever happened. Because he had no idea. He had no memory of it. Older people, the way that they metabolize anesthesia drugs and gases is a lot slower because of the normal aging of the kidneys and the liver. So they can be pretty cuckoo nuts bananas those first couple days after surgery. Okay. Alcohol or substance abuse, obviously. Prolonged ICU stays, as in ICU delirium. ICU delirium is a type of delirium specifically in patients that are affected in the ICU. This is due to sedation and pain meds, sleep deprivation from all the alarms and constant care, which is valid, and then psychological stress from being in the ICU. It's important that during the day we open the patient's blinds and we let the sun in and we tell them that it is daytime. It's important at night that we turn the lights down low and we have lower stimulation and the blinds are closed and the TV's not blaring and people aren't screaming out in the hallway, right? Because their circadian rhythm is important to maintain. When your patient is sedated on a ventilator, it gets real crazy up there, and your patient's on sedatives, they're on propofol, they're on Versed, they're on fentanyl, God forbid they're on ketamine. They are tripping balls, okay? They are not okay. They are not in the same universe, okay? And it can be very, very scary for them. And some people even remember like horrific things that they think they saw or thought or they did see or hear while they were in the ICU, okay? Super scary. Symptoms can fluctuate throughout the day. Confusion and disorientation, agitation or restlessness, inattention, disturbance of consciousness, ranging from drowsiness to severe agitation. Disordered thinking or perception such as hallucinations and delusions. I had this one lady, back before I was a nurse, I would get pulled to sit sometimes. And this lady, she thought she was standing in her bed. Like, she's laying in her bed, right? But she swore on her life that the bed was standing straight up. So, like, she was standing there and the bed was behind her, but she was standing in the bed and she was going to fall out of the bed. You are laying down. I mean, like, literally scared for her life that she is going to fall out of this bed. There was nothing that I could say or do to convince this woman that she was laying in her bed safely. That was a very
That's so
long
funny because I had a patient like that too, and it was a long, long night.
It was a
because
very
she
long shift.
was terrified. I mean, she was crying and everything. She was literally
Oh,
terrified that she
absolutely.
was
And it's
falling,
the
and I was
fear.
just letting her fall.
The fear is so real. It is so intense. And especially in that position, you know, I was like 23, 24. Like I had no idea what was happening. I wasn't, I mean, I think I was in school, but like it freaked me out. Anyways, rapid changes in cognitive function, and then the sleep-wake cycle disturbances, which I already talked about, your circadian rhythm. We have what's called a CAM scale. CAM stands for Confusion Assessment Method. This is an evidence-based tool that's used for detecting delirium. Any positive CAM score, if it is positive in any way, shape, or form, requires immediate further investigation. Okay. So you want to assess for the onset and fluctuation, the acute, if it's acute, delirium is acute. It's not a chronic issue. So is the change in behavior acute or chronic? Is the thought process sudden? Is it fluctuating or constant? Is the patient having difficulty focusing their attention and becoming easily distracted? Like you're trying to talk to them about something and they're like, ah, da, 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 right? Like my friend back here looking at the cars outside. Disorganized thinking is the patient thinking disorganized or incoherent, constantly switching subjects, irrelevant topics, illogical flow of ideas, things that just don't make a lot of sense. Okay. And then overall, what is the patient's level of consciousness and wakefulness? Are they alert to self? Do they know where they are? Do they know what month or year it is? Okay. Are they alert at all? Could you do a GCS? Sure could. Sure could. Your treatment is, we already talked about this. The goal for delirium is to treat the underlying cause because it is reversible. If we want to reverse the delirium, we have to treat what's causing it. So if it's an infection, get some antibiotics. If the patient is withdrawing from a substance or alcohol, we can really only provide them supportive therapy while they withdraw. Specifically, alcohol withdrawal can 100% kill your patient. Okay, it's extremely dangerous to withdraw from alcohol at home. You could have seizures, you could cardiac arrest, you could die. You have electrolyte imbalances. It's very scary. So it's important that we provide supportive care. And sometimes that supportive care turns into that patient being 4-point restrained to the bed with a Presidex drip and getting 4 milligrams of IV Ativan every hour and still hallucinating, which is crazy. I've seen it. Crazy. So it's very important that we support those patients in safely withdrawing from a substance because that's the first step of recovery is withdrawing from the substance. Okay. Severe cases of delirium can put a patient at risk for harm to self or others. So if we have to, we have to medicate, right? Are drugs considered a restraint? Yes, a chemical restraint. Can you physically and chemically restrain someone? Hell yeah, I just told you can. Abso-darn-tootly. This dude was so out of his mind that he was maxed out on Presidex, getting 4 milligrams of Ativan every hour and 4-point restraint to the bed, and he was still sitting up in the bed hallucinating that his daughter was in the room with him, and he was crying and talking to her and begging her to forgive him. And we could not drug him any farther without having to intubate. It was a long night. It was a very long night for him. It was really sad. So in order to help with these types of situations, we have antipsychotics. Most commonly, we have Haldol, we have Geodon. Those are both antipsychotics that can be given for situations like this. It does not happen like it does in the movies where they come up to you and they shoot you like in the neck. Or like stick a needle in your leg or arm and then you automatically just go limp. That's not real. That's not real life. It takes anywhere from 10 to, well, depending on what you're shooting them with, like if you were to give them ketamine, that person is going to be down within 3 minutes. And that's a pretty crazy thing. I've only seen ketamine given like that, IM, once. And it was actually in the OR. We had this big autistic kid that was like trying to fight everybody. And literally the parents, the dad couldn't even restrain this kid. And we had to give him a ketamine shot. Geodon and Haldol, they take a little bit longer, anywhere from like 20 to 30 minutes, depending on the absorption of the medication. And then it just kind of like slowly like onsets. Like it's not like the patient just drops in front of you. You know what I mean? But then that sedation can last a significant period of time. If you give medications IV, like you're giving IV Ativan, IV Versed, anything IV is going to happen very quickly, okay? Your main priority for any of these medications is to support your patient's airway. This patient can 100% go into respiratory depression and then die of a respiratory arrest, okay? So this is not the patient that you get sick of dealing with, shoot up with a bunch of drugs, and then walk away and don't check on them for the next 6 hours. Because you may come back to your patient dead. Especially if you don't have a telemonitor telling you that your patient is dead. Okay. Nursing interventions, we always want to reorient the patient, provide emotional support. Now, I borderline disagree with this, depending on the patient. If reorienting your patient is making them more aggressive, stop. It's unnecessary for you to constantly recorrect and reorient a person that is just getting very, very aggressive, telling you that you're wrong. You're just fighting with someone. Why? Why are you doing that to yourself and why are you doing that to the patient? Okay, just stop. Sometimes we have to give in to delusions to keep peace. And I'm not talking about anything that has to do with safety, obviously. But I had a guy once that swore he was at the casino. And I'm sure a lot of you guys have seen an activity apron. And if you haven't seen an activity apron, it's literally an apron and it has pockets, it has zippers, it has things you can tie, it has buttons. It literally has a bunch of activities like a toddler. And I gave him, I gave him a couple quarters, and that dude for like 3 hours just messed with all of these pockets and his little coins because he swore he was at the casino and he has chips. He had his chips in his hand. What am I gonna fight this dude for? You're not at the casino, you're at the hospital. Why? Why? Just to piss him off? No, absolutely not. I will say one of the best things that ever happened that night was he looked at me, he turned to me 1 second and he goes, "You better get out of here." And I'm like, "What? Like, what do you mean?" And he goes, "My wife's coming and she's gonna beat your ass." I said, "Oh no." I met his wife the next day. She was very pleasant woman, but he did not like having a young lady at his bedside in the middle of the night because he knew his wife was going to be pissed. Now that's the kind of man I'm looking for. If my husband doesn't do that, bye. Anyways, reduce environmental stimuli. We already talked about that, especially in the ICU. Promote safety, bed alarm, close to the nurse's station, one-to-one sitter if necessary. Teach relaxation exercises. Utilize restraints and medications needed to promote safety. This is the last resort. Is it very common? Yes. Is it still the last resort? Yes. This is a whole subject that I want to get into after lunch. How do we feel about that? I feel like it's time. It's only been 2 hours and it feels like longer. So let's take, what time are we here till? That's it?
1:30.
Oh no. Okay, 20 minutes. I didn't realize, I thought it was like a 2:30 or 3 day. Shoot.
Say we're here from 9:30 to 2.
Okay, so Wednesday is a 2. But then Wednesday is the math exam too. Okay. All right, 20 minutes. Come back at 11:45. Yes, this week is all neuro, but I mean, it's so much. Spinal cord injury, cranial nerves, Glasgow coma scale, strokes. Like there's just so much content in this one subject. So 11:45.
There's mine.
Bobby, your microphone. Oh, never mind.
Okie dokie.
I think they're gonna turn the heat on when it's 85 degrees outside since they've had the air on all winter.
Great question.
I remember it being really warm last summer in here. Sweat.
Oh, yeah, I just got so cold. I always get cold like after lunch, and then as soon as I start talking, I'll take my jacket off. Okay. So we are going to talk about increased intracranial pressure. So a very important concept to learn about ICP is that the Monroe-Kelly hypothesis, okay? Because there is such limited space in the skull, there is a balance between three things. That balance is brain matter, so your actual brain, blood, because we need the brain to be perfused with blood, right? And then the third thing is cerebral spinal fluid, which we must have. Okay? So we have to have all three of those things at the same time. And all three of those things are allowed to take up a very specific amount of space. So the Monroe-Kelly hypothesis says that because of the limited space in the skull, an increase in any one of the skull's components, which it could be CSF, blood, or brain tissue, necessitates a change in the volume of another. Okay? So if your brain is hemorrhaging and a bunch of blood is pouring into your skull because it's bleeding, there's no room for the other stuff. So what happens is that the CSF gets pushed out, and then the brain tries to get pushed out, which is what we call brain herniation, where the brain, there's only really one hole in the skull. I mean, yeah, you have your eye sockets, but that's not really a hole that leads to the brain. There's something behind your eyeballs, right? Like your whole orbit. The only actual hole that we have in our brain is back here, where your brain stem comes out into your spinal column. Okay? And I think that's called the magnum foramen or something like that. Anyways, that is the only opening that we have in the skull. Okay? So when we have brain herniation, that's where it occurs, where the brain contents come out through that hole. And is one thing that can cause brain death. So say it's something else. It's not blood. It's CSF, okay, cerebral spinal fluid. You have an increased amount of cerebral spinal fluid in your brain. So that means if that one is high, the other two have to be low. So the brain isn't getting enough blood, which means it's not getting oxygen. And also the brain tissue has to go somewhere. Okay? Now let's go the other way. If the brain tissue is swelling, we have what's called cerebral edema. The brain tissue is taking up all the space, forcing the CSF and the blood out. You see where I'm going with that? Okay? So if all three are not in balance, then that means one is high, the other two are going to be low. Not good at all. Okay? So increased intracranial pressure leads to decreased cerebral blood flow, meaning decreased oxygenation to the brain. What happens with that? Hypoxia. What happens when we have a brain without oxygen? brain dead. TBI, brain dead. Okay. So increased pressure in the brain leads to the brain getting squeezed, brain swelling, which is edema, cerebral edema. This can lead to herniation if not treated, which means, like I just said, herniation occurs, displacement of the brain due to the severe skull pressure, and it usually comes out of the back of the skull, the base where your brainstem is. The normal intracranial pressure is between 5 and 15 millimeters of mercury. Yes, you should know that. And a ICP greater than 20 needs immediate treatment, and this is an emergency. Okay. So, increased intracranial pressure, the symptoms. We have decreased level of consciousness, which is our earliest sign. And that can be confusion, less arousable, any decrease in the level of consciousness. Okay. Visual changes, headache, seizures, vomiting without nausea. See that? Without nausea. So it's just sudden vomiting with nothing preemptive about it. Behavioral changes, a positive Babinski. When is a Babinski good? And a little teeny baby, little baby. Okay. A positive Babinski in a full-grown human is not a good thing. Abnormal posturing, which can be decerebate or decorticate. Remember, decorticate to the core is flexion in. Decerebate is extension out. Decerebate being worse. Neither of them good. Decerebate is worse. Hemiplasia, this is paralysis of one side. And then very important to know is Cushing's triad. Cushing's triad is the latest sign of increased intracranial pressure. It is characterized by three things. We have a widened pulse pressure. That means that there is a very big difference between the systolic and diastolic pressure, okay? So instead of a 120/80 where there's a 40 millimeters of mercury gap, right? Normal. We're talking about a gap that's extreme. That's 180/60, right? That would be a huge widened pulse pressure. Bradycardia, heart rate less than 60. Irregular breathing. These three things together are called Cushing's triad, and they are a warning sign to the brain herniating. This is bad. Bad news bears. Okay. Treatment. We must treat the underlying cause. What is causing increased intracranial pressure? Is it hypertension where you have too much blood flow to the brain? Is it infection? Is it a brain tumor? Okay. The treatments, they can be surgical or pharmaceutical. So we can have a craniotomy. Craniotomy is when we remove part of the skull to ease the swelling. That happens a lot in traumatic emergencies where someone has acute cerebral edema, and in order for them to let the brain have room to swell, they remove part of the skull. Because if you don't, and the brain swells, what happens to the other contents? They go down. So the brain gets less oxygen, and then a hypoxic brain is not a good brain. Okay. So this is a way to allow the brain to have room to swell. A ventriculostomy, this is a drain to reduce pressure of cerebral spinal fluid. Okay. And we'll talk about the different types of ventriculostomy drains. We have medications. There are two main medications. There's one diuretic that is specifically for increased ICP, which is mannitol. Okay. Mannitol is an osmotic diuretic and decreases intracranial pressure. Acetazolamide is also, hold on, I don't want to say anything wrong. Most of the time, acetazolamide is used for glaucoma to decrease eyeball pressure. So there are two types of diuretics that can be used. The most common one is going to be the most one that you guys know that I taught you would be mannitol, which is an osmotic diuretic. Acetazolamide is a carbonic anhydrase inhibitor. It is a very specific type of diuretic. It only has one medication in its class, which is acetazolamide. It can reduce CSF production. It can improve visual symptoms. Trying to see the dosage. Because I've only seen it as an eye drop, but it has to be able to be given in a different way. Sorry, I just don't like giving you guys bad information. I don't like having to take back the words that I say. Okay, so acetazolamide can be administered orally for increased ICP. It can also be given IV in acute or severe cases. Okay. And I swear there was something important I wanted you to know about acetazolamide. I'll remember it. Somebody write that down and remind me, because I know there's something important that I need you to know about acetazolamide. And we'll probably just get to it on the slides, but I want to make sure I don't forget. Pressors or antihypertensives to maintain blood pressure for ICP. One thing in neurology that you'll hear of, especially with strokes, is called permissive hypertension. It's when the patient is allowed to be hypertensive. They want the patient to have a goal blood pressure of like greater than 140, greater than 160. And that's up to the neurosurgeon or neurologist. But that is a common occurrence in neurology. Barbiturates can lower the ICP, and then anticonvulsants to prevent seizure activity. Mannitol is a concentrated sugar that draws water from the brain into the blood to be excreted. If you don't remember from advanced pharmacology, a huge contraindication to mannitol is CHF or any type of pulmonary edema. So it says monitor for signs of fluid overload, crackles, JVD, edema. It is contraindicated in a patient with a history of CHF or symptoms of pulmonary edema. If the patient has a new onset of pulmonary edema, you need to stop the mannitol and notify the provider. Okay. Nursing interventions for ICP is you need to closely monitor the patient's vital signs, neuro checks. This could be every 15 minutes. This could be every half hour. This could be every hour. This could be every 4 hours. It depends on the order from the physician. In a very acute neurological situation, you're most likely going to be doing neuro checks every 15 minutes. Okay. Monitoring the ICP, we're going to talk about how we can do that with the different types of drains. Electrolytes, airway, and breathing. Depressed breathing can lead to hypercapnia. What is hypercapnia? Too much CO2. Hypercapnia. High CO2. What does high CO2 lead to? What kind of metabolic? Oh, we can't talk about that. Never mind. Never mind. We'll talk about it on Thursday or Wednesday. So decreased breathing can lead to hypercapnia, which can cause cerebral vessels to dilate and ICP to rise. Okay, so we don't want the patient to be retaining a bunch of CO2. It's going to make them worse. Okay, of course, eyes and nose, the patient's on a diuretic. Yes. We want to, in order to maintain the intracranial pressure, we need the head of the bed to be equal to or greater than 30 degrees. One of the very first things that you can do for a patient that is symptomatic of increased ICP, the very first thing you should do, you should write that down. Sit them up. Okay. Avoid the Valsalva maneuver. Any type of vagal maneuver, bearing down, coughing. When you have a patient that is intubated or trached, and we've all seen the inline suctioning, right? We've all been in the ICU. We've seen the inline suctioning, okay? It's pretty long. I mean, it's like this long, okay? What is right here at the bottom of your trachea where your bronchi split? Do you remember what that is? No? I mean, I like your line of thinking, but no. Inside. So at the bottom of your trachea, where your two bronchi split into your right and left main stem bronchi, the very middle where they meet, that is called the carina. Okay? The carina is a very sensitive place. It does not like to be poked. And when you go down and you suction your patient and you're doing it vigorously and your patient is bucking off the vent and coughing, it's because you are stimulating their carina, okay, causing a Valsalva maneuver, which triggers the vagus nerve. This all leads to increased pressure in the brain. You know, when you're coughing really hard or vomiting really hard and your face is all red and your head's pounding, that's increased intracranial pressure being caused by that stimulation. Okay, so would I want to continuously suction a patient that has high pressure, intracranial pressure? Abso-darn-tootly not. And I'm going to be damn sure careful about it. Okay. Decrease stimuli. I don't need all this crazy stuff happening around my patient. Okay. We need calm environments. Clustered care. That's not all crazy. Okay. Seizure precautions, that includes suction at the bedside, always, 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 always. You should always have suction at the bedside anyways, whether or not you have seizures or not. But if a patient has seizure precautions, they must have suction. Oxygen setup just in case, padded side rails for safety, and the bed in the lowest position as, you know, because they might fall out. Okay. So this slide is all about different types of ventriculostomy drains. So a subarachnoid bolt, this is literally a bolt that goes into your brain. Okay. The only job that it has is to monitor the level of ICP. It does not drain anything. It only monitors. Okay. No drainage, only monitor. Then you have a ventriculostomy drain. We really refer to this as an external. Okay. And this monitors the ICP and drains the CSF to control the pressure in the brain. Okay. Then you have what's called a ventriculoperitoneal shunt. We shorten that, we call that a VP shunt. There's also a VA shunt, which is ventriculo arterial shunt. And this is permanent drainage of CSF, and it does not monitor. It doesn't give us any type of number. This is surgically implanted permanently into the patient's body. Okay. Ventricular peritoneal. That means it goes from the ventricle in that patient's brain. And to actually witness this is so crazy. Crazy. So there's a tube that goes into the patient's brain. It is tunneled underneath the skin, down the patient's neck, and then they get this big hollow metal rod, depending on the size of the patient. And usually this is placed pediatrically, which is why I've seen so many of them, because I worked in a pediatric OR. And they get that big rod and they put it under the skin and they shove it down the patient's body under the skin. I know. And then they tunnel that tubing all the way down. And then the tubing ends in the peritoneum, which is your abdominal cavity. Okay? Where that excess fluid just gets absorbed into the body. Okay? This is the most common type of, we had a child on the bus that I used to drive who had a VP shunt. Everyone had to do special training in case of emergencies. That is correct. That is correct. And that drains into the peritoneum. If it's a VA shunt, it will drain into the heart, into the right atrium. Okay. Either way, our body deals with the extra fluid. Either way. Okay. It's better in the body than it is in the brain, because then it causes symptoms of increased intracranial pressure. And eventually, if it's too much, it can lead to brain death because of hypoxia, right? Because of the Monroe-Kelly hypothesis. Okay. So what do you think is the most important thing for a patient with a VP shunt? Acutely post-op. I just went into your brain. Like your literal
Neurological
brain.
assessment.
What about infection? Infection. Huge, huge risk of infection. There's not supposed to be, guess what? That blood-brain barrier can't help you if there's a hole in your brain. Okay? Totally neurochecks. And then what happens, and this is what Hannah's talking about in the comments, in case of emergencies. What kind of emergencies? What could happen to this drain? This drainage system, Hannah? What could happen to our patient's drainage system? She's trying to unmute, I think.
Yeah,
She's
I was
lost. She's like, why are you
sorry.
talking to me? No, you're fine.
Trouble with my button. If I remember correctly, I think it was because they said that if they had any like head trauma, it could cause it to disconnect.
Okay. Yes. Yes. So a patient that has a VP shunt or a VA shunt, if something happens to their drain, like it gets disconnected, which it happens, it's not the most common thing that happens, but it can happen, especially with injury. What could happen? Fluid's going where it's not supposed to go, right? Where did it get disconnected? Did it get disconnected up here? Is it just free flowing into the skull or into the surrounding scalp tissue? Did it get disconnected here and you just have fluid in the subcutaneous tissue of like the neck? Did it just get disconnected in the peritoneum? I don't know. More commonly, the tubing gets clogged. Something happens to the tubing, it gets kinked. Obviously, this is not a very super strong tubing, right? This patient's living with this for the rest of their life. It's a long, flexible, thin tube. It tunnels underneath the skin. You shouldn't be able to see it unless the child or person is very, very thin. Like I'm talking extremely thin. Like right before my mom passed, you could literally see her Metaport tubing because she had just no subcutaneous fat in that area. So if that child or patient is like extremely, extremely thin, you could see the tubing theoretically, but you're not going to. So if that tubing gets clogged, what do you think is going to happen to our system? It's going to build up. The pressure is going to build back up. So what do you think our caregivers or our nurses or our doctors or our school bus drivers or our teachers need to know about my patient? What is my first sign of increased intracranial pressure?
Change in level of consciousness.
A decreased level of consciousness. All of a sudden, my patient just got confused. That's weird. Because, by the way, these kids can live a perfectly normal life. Just because they produce too much CSF doesn't mean there's anything wrong with them mentally or physically. Most of these kids get these drains put in when they're babies, and they have them for the rest of their lives. By the way, guess who is usually the first person that says, hey, my shunt is malfunctioning? The patient. Something's wrong with me. There's something wrong with my shunt. And they take their own ass to the ER and say, hey, my shunt is messed up and I'm gonna need you to do something about it before I go cuckoo nuts bananas. Okay? It's different with kids and it's different with older people. And obviously depending on the patient. I'm not saying that all patients that have this condition are 100% neurologically intact. But what I am saying is just because a patient has this does not mean that they cannot live a perfectly normal life. Okay? So it's extremely important.
Rowdy, because that child on my bus was the most rowdy kid on my bus.
I bet you he was normal too. He was a normal kid.
Absolutely.
Well, whatever normal is, right? Whatever we want to call normal these days. My kid's crazy. I don't think he's normal. Anyways, that's a good point, Hannah. Thank you. So knowing the difference between these is very important. I think it's the next slide. Yes, okay. So indications for this to occur is hydrocephalus, which literally means water on the brain. And usually patients are born with hydrocephalus. So this is your babies or children that get these VP or VA shunts as very small humans. Okay. A traumatic brain injury, so something that causes increased cerebral edema or increased CSF. It could be acute or chronic. Meningitis, which is inflammation of the brain. Okay. So basically anything that can cause CSF buildup in the brain. This is not for hemorrhage. This does nothing for bleeding. This is only for cerebral spinal fluid. Okay. This is a picture of an external ventricular drain, which commonly is referred to as an EVD. So you see, see this little water cavity in the brain in the picture? It's blue in the picture. That's normal. We all have ventricles, these little cavities in the brain, and CSF lives there. That's normal. Okay. Everyone has that. It's when there's too much CSF that's produced that makes it abnormal. Okay. So for an external ventricular drain, it's a catheter placed in the cerebral ventricle up here into the noggin, into that space where the water is. I'm just going to call it water, where the fluid is. And it is only temporary. This is a temporary drainage system. Okay. For nursing interventions, the pressure scale must be lined up with the level of the tragus. The tragus is this little guy on your ear. If you didn't know, this little guy right here, that's your tragus. So if my patient is sitting up in bed like this, I mean, this is probably a good, I don't know, 60-degree angle. And they're sitting there just like this, not moving, watching TV. My system needs to be level with their tragus at all times. At all times. Okay? So if it is too high, it can act like a vacuum and can cause excessive drainage. Anybody have an epidural go wrong and need a blood patch? Anybody? There's got to be somebody in this. There's 40 people in here, and most of us have had babies, and not one of you has had an epidural headache. Really? Lucky group. Lucky group. I thank God I didn't have one. When you have a lot of CSF removed from the brain, it is super painful. It is very painful. The CSF is like the brain's lubricant. It's the lubricant for the brain to work, right? The blood is like the gas. I don't know nothing about cars. What's important to cars? Coolant? How about that? No, maybe? I don't know, something. Anyways. Somebody chime in if you don't. I don't know nothing about cars, but I'm trying to put it in a sense where you understand what I'm saying. So when you take away that CSF from the brain, it's not good for the brain. Okay. If you don't, well, the brain doesn't overheat, so I don't want to do that. Anyways, oil maybe. Okay, oil's the lubricant. Okay, so the blood is the gas.
right? The brain is the motor and the oil is the CSF, right? You can't have too much oil and you can't have too little oil. You need just the right amount. Ah, okay, that works. All right, so if the CSF is too, or I'm sorry, if the, come on, Jessica. The level with the tragus. If it's too low, then not enough suction is happening. The CSF won't drain or will backflow, causing an increase in intracranial pressure. Okay, so it's very important that it is level with the tragus. Sorry, my glasses are filthy. You want to monitor the hourly CSF drainage. That is very important. By the way, this patient is in a neuro ICU. Okay. This patient is either, depending on staffing, is either a 1-to-1 or you only have 2 patients and your other patient is easy peasy. Okay. Because this patient needs a lot of assessment. You have to make sure this patient is safe. This patient is leveled. This patient is not symptomatic of neurological symptoms. You have to be checking on this patient constantly. Okay. So hourly CSF drainage, if you notice on this picture, can you see my picture? So you see this chamber here where it's marked chamber? See that? Yes. Okay. This has like little notches, like 10 mLs, 20 mLs, 30 mLs, 40, 50, and so forth. This down here is your drainage bag. Okay. So, and right here in the middle is a stopcock. All right. So this is turned off. So all of the drainage for the hour is collected in this chamber. Okay. You go in, you say, oh, 20 mLs. You go to the little stopcock, you turn it, it goes into the drainage bag. You turn the stopcock back to close it. And then in another hour, you go and check your chamber again. That is how we do hourly outputs when we're talking about an EVD. Okay. So it would be very important that you don't leave that stopcock open, because how do you know your hourly drainage if it's just freely draining? That would suck. That's the whole point of the chamber being there. Okay. Monitor the ICP. If we have an EVD, we can drain and monitor. If we have a bolt, we can only monitor. And if we have a permanent, we can only drain. Maintain the head of the bed at 30 degrees, leveled to the tragus unless indicated, unless specifically, you specifically have an order that is different. Okay. Clamp the drain before repositioning. Remember to unclamp once it is leveled. Okay. So if you need to go in and do a bed change, and I'm not trying to hurt my back, I need to lift the bed up, right? Me and you go in the room and we go to do a bath and a bed change. Well, am I going to clamp it, lay my patient down, do all the things I need to do? Or am I going to try to like keep leveling it while I'm rolling the patient around and bringing the bed up and putting it down and doing all kinds of stuff? No, I'm going to clamp it. I'm going to provide the patient's care, do all the things I need to do, make sure they're okay. I'm going to get them situated, re-level, and then unclamp. Okay, that is the proper way. Because what happens when if it's too high or too low? Bad things happen. Okay. Frequent neuro checks and vital signs, maintain dressing and change per order, because remember, this is an external device, so there's a big old hole in the patient's head. So we need to make sure that the patient's and nice. When to notify a physician? If no drainage occurs for an hour, there could be an occlusion in the catheter, which could lead to increased intracranial pressure. We are constantly producing. Our body, it's just what it is. The thing is that we produce when we need it, and then it's a act of homeostasis. When a patient has hydrocephalus or a TBI or meningitis or whatever, it's causing that normal feedback system to not do what it's supposed to do, right? So no drainage in an acute situation is not a good thing. You don't go in there and you're like, oh yes, there's nothing here. No. Okay. A lot of drainage suddenly occurs. The doctor may ask you to adjust the level or clamp the drain. Why? Why is there a huge output? That is not a good thing. Clots or tissue debris begin to drain. What does CSF look like? It's clear, almost iridescent if you shine a light into it, like a prism, but it is clear. So if there's anything inside of that drainage, that is bad. And then drastic change in the ICP, whether a VP shunt, we already talked about this, but during the hospital stay, unless you work at a pediatric hospital or a situation where a patient has an acute encephalopathy that then needs like a chronic drain placed, you're most likely, if you see this patient, like I said, has had this their entire life, okay? So most likely you're not going to have a lot of post-op care unless you work in pediatrics. Now, you can have post-op care if that drain becomes clogged and they have to go in and change out the tubing. That is one of the biggest complications when it comes to a VP or a VA shunt, is where is the occlusion and how do we fix it? Okay. So if that happens during the hospital stay, you're going to have neuro checks and vital signs, pain management. You want to monitor the incision site for any signs of drainage, infection, ICP monitoring. With a VP shunt, you don't have a monitoring system. So really you're looking at a neurological orientation, level of consciousness in order to evaluate this. And then assist the patient with ADLs, position changes to avoid increased ICP from straining. Upon discharge, education is extremely important. You do not want the patient to touch the site, okay? It is open, it is healing. We do not want meningitis. Avoid high-risk activities because high-risk activities are going to naturally increase the ICP. To keep the incision clean and dry, no showering until approved by the MD because you don't want water just running over it, and no heavy lifting for 6 weeks. The patient has to be checked at minimum with their neurologist every 3 years, neurologist or neurosurgeon. Encephalopathy, this is a generalized term to describe disease of the brain tissue that alters brain structure and function. There are a lot of different reasons for encephalopathy, okay? So encephalo meaning brain, pathy meaning disease. Multiple causes include infection, trauma, toxemia, anoxia, which is no oxygen. Toxemia, that's usually referring to alcoholism. Alcoholism causes encephalopathy because of the liver and the toxin buildup. So encephalitis refers to inflammation of the brain tissue itself. Encephalitis can cause encephalopathy. Encephalopathy refers to a decreased mental state due to a variety of factors that can cause brain dysfunction. So This is going to present as neurological symptoms. This is where the tissue can be swollen. It can be, so again, I'm going to use my mom as a reference. My mom had metastatic breast cancer where she had a brain tumor. The brain tumor, when it got bigger, it caused symptoms of encephalopathy because it alters the brain function because it was pressing on the brain matter and causing swelling within the brain. Okay. So it eventually symptoms, the bigger it got, right? I see a lot of older people at the hospital with metabolic encephalopathy. Absolutely. Absolutely. So when it comes to encephalopathy, is it infection? Can we treat it? Trauma, can we alleviate some of the stressors from the trauma, offer support, and it gets better? Anoxia, it doesn't get better. Unfortunately, when the brain dies of lack of oxygenation, it doesn't come back. And then toxemia, can it get better? I think it depends on the patient. It depends on the cause of the toxemia, I believe. So types of encephalopathy, we have acute versus chronic. Acute is reversible. That is the most important thing about this. Acute is reversible. Chronic is irreversible. So Wernicke's encephalopathy is caused by a vitamin B1, which is thiamine deficiency caused by alcohol abuse, malnutrition, or malabsorption. Most commonly, it is caused by alcohol abuse because alcohol stops the absorption of B1. Uremic, this is urea buildup secondary to renal failure. Hepatic, this is ammonia buildup secondary to liver failure, whether that is alcohol related or not. Toxic metabolic, this is a toxin buildup due to anoxia, infection, metabolic imbalances. Hypersensitive, this is hypertensive. This is severe hypertension leading to cerebral edema, which causes increased ICP. These are all reversible if treated promptly, by the way. So chronic, we have traumatic. This is repeated trauma to the brain, like accidents, contact sports, concussions. Hypoxemic, ischemic. This is decreased blood flow to the brain tissue, whether it be from cardiac arrest, a fetal infection, any type of tissue death caused by hypoxia. It says changes may occur acutely, but are irreversible. I already said a lack of oxygen, hypoxia, anoxia is irreversible. Spongiform, this is from prion disease. This is super scary. Prions are absolutely horrendous and will just eat your brain away and there's no cure. Hashimoto's, the exact cause is unknown, but Hashimoto's is related to hypothyroidism. It's an autoimmune disease, and it may be due to the inflammation from the abnormal immune response because it is autoimmune. And then glycine is due to the deficiency in an enzyme that breaks down glycine, which is an amino acid. Amino acids are proteins. Okay. This is the last thing we're going to talk about today. When we discuss brain death, this is sustained severe neurological injury that's incompatible with life. They must meet. I believe, let me make sure before I say it. All core clinical criteria for brain death, specifically irreversible coma, absent brainstem reflexes, and apnea, which is no spontaneous breathing, must be met to declare brain death. Okay. So, number one, no evidence of arousal to maximal external stimulation. So this is sternal rubs. This is nail bed compression. This is getting a hemostat and like pinching. This is, and I'm not kidding, this legitimately happens in neurological ICUs when they are testing brain death, like straight up purple nurbles. Straight up. And you think like it's, cruel, but like, I mean, if you're telling me I'm brain dead, you better make sure I'm brain dead. Right? So this is one way they have to make sure that you have no response to maximal painful stimuli. Number two, the pupils are fixed and dilated. There is no pupillary response. Number three, an absent corneal reflex. 4, there is no facial movement to noxious stimulation. There's no grimacing. There's nothing. Nothing. No gag reflex. This is important. You're going to see in the ICU when hopefully you're with a nurse and you're doing your head-to-toe assessment. I want you to watch them do their head-to-toe assessment. If your patient is intubated and sedated, they are going to stick that Yankauer down that patient's throat, and they are going to try to get their patient to gag, because that is a brainstem reflex, and we need to make sure that that reflex is intact. Okay. Number 6, no cough reflex to deep tracheal suctioning. I'm talking tickling the carina. No cough response. That is also a brainstem response, I think. Don't write down the brainstem thing. Okay, yes, it is. They are both brains. I just want to make sure, I hate saying wrong things and I'm going to take them back. So both your gag and cough are brainstem reflexes, which is why you can't declare brain death just on like pieces of this puzzle. Okay. They all have to be in check to declare brain death. And then number 8 is there's no spontaneous respirations with the apnea test. Specifically, I want you to put a little hyphen, without any, none whatsoever sedation or analgesics. No propofol, no Versed, no fentanyl, no morphine, no Dilaudid, no ketamine, nothing. Nothing. That means that there is absolutely no reflex to breathe. Why do people drown? Do you think they choose to inhale water? No. It is your brain that is starving for oxygen, that you get to a point underwater where it is no longer voluntary, and your brain, in its basic reflex, is going to force you to breathe. So in order for brain death to occur, you must have no spontaneous respirations. Okay? Okay. Last term when I taught this before, I had a student that I believe it was her brother was on life support. They were trying to determine brain death. They ended up having to withdraw care. And she kind of struggled in that moment because all this time, she was young. This was before school. This was before anything. And when you're in that situation, your family's in that situation, you're really leaning on your providers to educate you and help you make the best decisions. And he didn't fully meet complete brain death criteria, but they still recommended withdrawal of care because he would have been in a complete vegetative state. All he had left were brainstem reflexes, which were that gag and cough. And they really had to weigh out basically, do you want to keep this person alive, trached on a ventilator for the rest of his life in a vegetative state, or withdraw care when there's no quality of life and there's no coming back? Because we talked about anoxia, there is no getting back that brain tissue. Okay. And it was a little difficult for her to like process in this moment talking about all of this because it was triggering for her. So can we withdraw care from a patient that has very, very low quality of life but is not brain dead? Yes. Yes, we can. The family can absolutely decide that. Is it hard? Yeah, it's really hard. But you can do that. Okay. This is where we're going to stop today. Any questions on all this? We covered a lot. Stuff that I really want you to focus on from the content that we talked about today. I need you to know all of your cranial nerves. I need you to know the GCS. I need you to be able to give me a number. If I describe a patient situation to you, I'm going to ask you, what is this patient's GCS? And you have to be able to give me a number. You will not have the scale. You will not have the scale. So I need you to know it. Okay. We're gonna do some case studies on Wednesday where we find the GCS together. Also, look up questions. Ask ChatGPT, hey, give me 10 GCS questions and practice doing GCS. Okay. I need you to know the big things about drains. I need you to know the symptoms of increased intracranial pressure and Cushing's triad. What to do if your patient is experiencing symptoms of intracranial pressure, increased intracranial pressure. Okay. And a little bit about the brain death. Okay. Questions?
Wait, and you said a little bit about the what? I didn't hear the last part.
Brain death.
What did you say before the brain death? Did you say Cushing's something?
Cushing's triad.
What was it? Sorry.
Cushing's triad.
Okay, thank you.
Do we need to go into depth like with the automatic nervous system and peripheral nervous system?
I want you to understand why it happens. Why is my heart beating faster? Why am I breathing faster? Why do I need blood sugar? Why do I need increased blood sugar? Right? I want you to understand the concept. Okay. I will be sending out CPTs, which used to be SAPs for your exams. I don't, they're like the SAP, it was like student academic progress or something if you did not pass the exam. And there will be a link. Does everybody have clinical on Thursday, Friday? I know you guys do. Who has clinical Tuesday? Anybody? Anybody? Nobody?
We have a VSIM on Tuesday.
Just this Tuesday coming up or every Tuesday?
We had it last
Just
Tuesday.
this
and this
Tuesday
Tuesday.
and this Tuesday.
Okay. I'm just trying to plan for test reviews because my office days are Tuesday, Thursday, Friday, and you guys are going to be in clinical on Thursday, Friday. Some of you get out. What time do you guys get out? Yeah, 1:30. So some of you have like a little bit of an early day. Some of you don't. I think some of you are still scheduled till like 3. I will have openings tomorrow. And then I will probably do a group exam review. Because there's just too many of you to meet all at once. If you get a CPT, aka SAP, from me today, then we need to meet like one-on-one. Okay. Okay. And the people that have the VSIM on Tuesday, schedule our meeting for a Thursday, not a Tuesday. You know what I mean? If you have clinical on Thursday, Friday, make sure those Tuesday slots are open for the people that need the Tuesday slot.
Is there like a calendar link or do we just coordinate the?
I will send you the link in the email.
Miss Simmons,
Okay.
how about if we don't need to, but we still want to meet with you to go over what we missed on the exam?
In that case, I will have a group review. And I don't know when that's going to be yet. Obviously Henry's super sick right now, so I've been known to do it on a weekend at noon during nap time. I've been known to do it on a Wednesday night at 7 p.m. while my husband's putting my kid to bed. It just depends on everyone's availability and when I can make it happen.
Okay, thank you.
Yeah, but I'll definitely let you know. Questions before you go?
Yes. Do you recycle questions for the final?
Remediate, yes. I have. Do I always? No. Have I? Yes. What?
For the test exam.
If you got below a 76, yes, you need to remediate for your exam.
What is that do?
When does that usually do? I don't know. 48 hours.
Yeah, some instructors have like 24.
48 hours. 48 hours. If you got less than a 76%, you must remediate and you upload it to the exam. There's the submission under, like it says exam 1, you go in there and upload it to that. Okay.
Miss Simmons, under our exam, like usually it shows like the topics that we missed. It doesn't show that on our exam.
That's because there's one person that still needs to take it, I think.
Oh, okay. So then that's why we have, so just wait to remediate then, obviously.
Oh, yeah. And that person is taking their exam tomorrow morning. If any of that changes at all, I will obviously extend that for you. Bye. If you guys are good, you're good to go if you don't have any questions.
Miss Simmons, I private messaged you.
Yeah, do you want to hop on after this? Like we'll exit out and then come back?
Am I able to meet with you tomorrow by chance?
Oh, yeah, I'll send you a message.
Okay, thank you.
Thank you. Have a good day. See you
You're welcome.
Wednesday.
Bye, guys.
Thank you.